No master here. Honored to follow the original PTP, the prone-to-prone PTP surgeon, and my talk is here. And I'm the professional naysayer, or the voice of consciousness, however you want to interpret that. I'm Jens Chapman. I get to work here, and I have a lot of fun, and it's an honor to speak in this meeting about the power of posterior. So herein, I concur with my preceding wonderful speaker. And considering deformity correction from the back and maybe beyond that, avoiding fusions. It's customary that we use conflict of interest declarations. And it's also customary to hear the lecturer say that there are no conflicts of interest in a reassuring fashion, but this is not the case here. I'm going to talk about something by a company called Extent and a company called Limiflex, with which I'm both deeply conflicted, and I'm going to point it out separately. There are a couple of other disclosures to make. One, and I want to credit the wonderful Dr. Neil Anand with the left-hand analogy, the Wolverine surgery versus KISS. I like KISS. I mean, you can think even less of me now, but I like simple, and you know what the acronym stands for. It's been going well for over 50 years. That's my age disclosure. And so posterior midline, again, we have these Wolverine spines that are all over now. And thank you, Neil, for this analogy. And I will, in the future, put your picture on there. So make sure that you are not the surgeon of these, but the inventor of this very appropriate acronym. When our maker gave us actually a beautiful access point, it's called the posterior midline. And this is also a debate about complex versus simple. My head is spinning about the various details that these masters like Martin leave the spacer just 2 millimeters out so you can navigate from it. I mean, this is amazing to see. And I'm a simpleton. It's very evident. I'm not intellectually capable enough to remember all these things. But it's also generational conflict. You see my receding hairline. And I'm from Gen O, so Gen Old versus the Gen Z people who show us what they can do, which is pretty darn cool. But the fact that you can do something does not necessarily translate into you should do this. And so the other aspect is a brutal one, and that's rigid versus flexible. Are we fusing too much? And the numbers are, in this country, steadily rising pretty dramatically. Now we have an aging population that's also more sick. But if you ask me, what is the incidence of adjacent segment disease next to a fusion? The answer is not 10% or 30%. And it does not matter if you've done perfect realignment or not. You can make it worse with misalignment. It is 100%. It's just a matter of definitions and how closely you're willing to look. And what thresholds to use to post-surgical magnification. So the point is that with better and better, cooler, less traumatic ways to do fusion surgery, are we actually providing patients with a lasting result, or is this an annuity proposition? And I think we're way too focused on fusions. Again, this is a side effect of fusions, and I do a lot of fusions, as the industry representatives in this room here can attest to, but many of them are revision surgeries. Easily a third of my surgeries are revisions of previous fusion surgeries. So the final conflict is that of magical thinking versus reality. And again, if we apply reality, we should not be oversimplifying, exemplified on the right-hand side, but hopefully common sense of one of our founding fathers, Thomas Paine, is a prudent common ground to kind of go to. And if we think about spine surgery, there are three things that we all agree on. That is effective and lasting, if possible, decompression of compromised neural elements. Number two, meaningful realignment and stabilization of the spine. And number three, a solid fusion where we want to fuse the spine. I think those are all three reasonable tenets that we can all agree on. And again, if we achieve the ideal state either with an open procedure, which is or can be pretty cool, or through a glass bottle hole, through really small things with a lot of technology around it, it's a matter of conjecture and interpretation of what your ideal goals are. But the three tenets should be fulfilled. And one problem that I have in this incisionally focused era is how long is the expected goal? I will rapidly concede that the less invasive surgeries lead to a fairly high patient satisfaction, not always, for the first 1 or 2 years. And after that, there's a pretty steep reality check. And that's, again, what I make a living off. So this is, again, a classic L4-5. This should be a no-brainer for all of us, degenerative spondylolisthesis. This was, assume, a Wolverine approach. Thank you again, Dr. Anand. And again, this is what I see in clinic. And this is just what Dr. Taylor said. There was no realignment done. I'm not sure where the hardware is. This is all navigated, percutaneous. There's not a real neural decompression in the foramina. It's just one of those things of, okay, somebody fulfilled the billing codes, and bingo, here we are, and now deal with the sequelae. So this is my proposition, what you can do with a single midline incision. No, this is not some major rape of the spine. This is a very focused, soft tissue-friendly incision and effective decompression, realignment, highly reliable fusion, even without BMP, and a very limited tech use. And yes, I love expandable cages. Thank you, companies, for making those. They are very good. So why are we doing these things, and do we really help patients when we hit them like this? I'm just not sure, but I actually, at the University of Munich, where I came from, trained as a general surgeon for the first 2 years. I love this anatomy. This is amazing. But do I really want to think about where the ureter is right now? Do I really want to scar the retroperitoneum for if this patient, God forbid, needs another retroperitoneal approach in the future? They need to have stents in their common iliac veins? Not really. So this is just, again, a fact of life, and I admire our colleagues who managed to navigate through all these tripwires. Yes, this is a real-life MRI 3D print from an MRI from Perry Godolphius, who really did a beautiful job getting this at 5-1 put into print. So the neurologic sequelae have been much batted around, and there's probably about a 1% to 2% long-term neurology. I know in the masses hands like Dr. Uribe, this does not happen, but these are actual published numbers that we came up with. And again, it's not a big surprise. And we're learning things that we've never heard of before, like the pseudohernia, that bulging abdomen, probably through a T11 or 12 injury. We've all learned intimidating things about the genitofemoral and the ilioinguinal neuropathies, rare things, but pre-disabling when you have patients come with weird scrotal pain after what should be a routine surgery. So briefly about fusions, again, we all learned how to do PSOs. This is a routine surgery for me, and feared because it was a pretty bloody surgery. And there was, again, always a neural or dural redundancy created during the shortening of the posterior column. And as an orthopedic surgeon, I actually have loved to have the thought of a neural balance, a neural tube balance, where there's no big folding, where you have a nicely properly tensioned dural tube, properly filled with CSF, with nicely falling off nerve roots present. So shortening the posterior column is a salvage procedure that I rarely do, but with so-called intradiscal osteotomies, which fulfills many of the principles that we've just heard lectured about through far lateral surgery. So you can actually achieve an extremely efficient deformity correction. It's a bilateral, more or less expanded T-PLIF, if you so will, with strategically placed hardware. After a nice release is done, the nerve roots should not be injured, and you can ask Dr. Cameron Hogshead, who's doing a nice expanded study now on IDOs and results for an unfiltered status check. And again, I usually place 2 cages unless it's an eccentric coronal deformity reduction, and you can get a very nice reduction and a very controlled low doses restoration with full neural decompression. Now again, this is my current clinic. One of those cases has been revised. The other 2 are still sitting around, but these are all patients who've had L4-5 or L5S1 fusions done in a variety of hospitals, not here. And they all start as a simple L4-5 fusion, however it was done. But these are truly pre-catastrophes, and I'm not particularly looking forward to 1 or 2 of those. That's a fact. The real problem is the following. As we're aging and having more and more degenerative spines, this is just a case of which I'm sure our clinics are filled with them. Mine certainly are filled with these. Aging patients are very unhappy with their spine, and yes, the MRI will show us multiple areas of some decay. The X-ray shows a somewhat imperfect structural balance. There's some neurogenic claudication, and the question to all of us is, what would we do? And the problem is now that the first go-to thing is, with the power of modern, phenomenal technology, fusions are done. I see a plethora, and I could show you lecture after lecture of L3 to 5 fusions that have expanded upwards and then downwards, are catawampas, and then get a posterior midline fusion. But this is what we see, and this is what we all know to be fusion disease. Was this really necessary? Well, this patient actually had severe neurologic problems from a dural erosion from one of those screws, so we took her back and did a nice IDO, corrected her. 1 or 2 level IDOs are very powerful. You can literally correct anything, 3 levels for sure, in terms of coronal and sagittal rebalancing. Like 3 or 4 months later, over the Christmas holidays, she came back and dislocated, despite perfect proximal, meaning rostral junction preservation, tapes, hooks, etc. No violation of midline structure. She dislocated. So this is pretty frustrating. Yes, we took her up to, I think, C7, and she actually did okay with that, but a year later she passed away from medical problems. But in the end effect, she was subjected to what is the corollary of a polytrauma by being hit by a small semi surgically at enormous cost with a very debatable benefit. When in fact, if you look at the origins of this and go back to the origin story, it's probably a neural impingement that really bothered her most. And yes, her spine is imperfect, but in our signaling, and here I'm daring to speak in front of many distinguished neurosurgical colleagues, the majority of our pain signaling is less from a little bit of an instability or a minor deformity. It's more from neural impingement. Do I have a concurrence? Let's say, oh, I don't get any attention from anybody. Here, Dr. Uribe.
Yes.
Neural impingement, is that a primary signaling thing over a minor instability? Yes or no? What does this patient on the right-hand side, without knowing anything else, primarily going to be concerned about? Their nerves hurt, they can't walk. That's my hypothesis.
I wouldn't say that is instability unless you show me flexion extension.
I know, I'm giving you an incomplete set of cards. I'm just asking a very fundamental neurophysiologic question. If you have compromised nerves over a bit of degeneration or a bit of instability, where's the primary alarm signaling going to? I hypothesize it's neurologic over anything else. Debatable. We can talk about it. So can we do something lesser than fusion? I know it's an imperfect image, but neural impingement is there. The big question, the Hamletian question, is literally to fuse or not to fuse, and maybe reduce the need for fusions. I do think, and even if you do a fusion, that doing proper midline sparing decompressions with partial facetectomies and feminotomies is a very powerful surgery. And by the way, the time-honored full laminectomy in our paper by Mike Lee, done in my UW days, shows a 32% destabilizing effect. So this is a substantial sacrifice that we do. It's basically 20% worse than if we do midline sparing hemilaminotomies. The other question is, can we do something with posterior stabilization? I'm showing you two conflicting devices that do the exact opposite. One is an interlaminar spacer seen on the left. The other one is a tethering device on the right. I'm conflicted with both, just to be very clear. I'm standing here and telling you I don't know which one is better, but I'm just going to quickly extrapolate on that. When we look at patients, we all have learned angles and we've all been indoctrinated in the sagittal balance, which is correct, of course. But this is actually a far more complex thing. And the main problem with standard alignment programs is that there's something called the neural escape posture. These are not static things that we're measuring right now with our surgeon map or whatever system we use. These are actually flexible things that are frequently, not always, a product of either sarcopenia, deconditioning, orthopedic conditions like hip or knee arthritis, or neurologic escape postures, the spinal stenosis forward bent posture. We all know that, we should know it at least. So there are multiple factors, I'm not going to read through all of those, that go into alignment beyond just the measurements. High discs, low discs, kyphotic angulation, vacuum discs, the severity slip. Yes, facet joint alignment, still not adequately categorized. Is there fluid, is there not fluid? Is it a sagittal, is it a coronal facet? Is it around 45 or 50 degrees or not? In conjunction with the disc height, this creates a dynamic environment for that particular space. The fluid sign is fascinating. We all know of it. We all have not really categorized it well. We have not also looked at facet tropism and dysmorphism or not. These are all factors that play a role in patients. So these are factors. When we actually added this up, and this has not been quantified yet, we actually come up with 15 things that play into a simple assessment of an L4-5 segment that have some role in what we do. So intuition, and maybe in the future some machine learning tool will help us aid this. But again, these are some things I just am showing you very briefly that play into our assessment of these patients. Now, when we looked at stabilizing devices like the Limiflex, I'm conflicted. They actually did pretty well. This is a tethering device posteriorly, and so this is getting FDA approved. So here, a couple of cases. 74-year-old farmer, lives alone, BMI high, type 2 diabetes. Farmers are the best patients in the world, sorry. They are unbelievable, and they usually can't stand the thought of being in a hospital. This is a morphologically poor patient by all means. That patient wants to be back on the farm as soon as possible. I did an outpatient surgery with a Coflex device. Yes, I'm conflicted here. Please note that. You can't ask for a happier patient. My clinic loves them also because these patients are actually very happy. Is this a perfect x-ray down here? Absolutely not. Have they been kyphogenic? Not really. Have patients been happy? Is this just enough stability maybe for some of those people? That's probably pretty reasonable to assume. This is a former professional model. She still comes to clinic looking like $1,000,000. She is very active, very healthy, very health conscientious, very thin, very fit, and again, grade 1 spondy. It's run of a mill. Here we gave her, she was part of the FDA trials, a Limiflex, the opposite idea, completely happy. I think she's 3 years out now. You can't beat that. Is it a perfect x-ray? Absolutely not. Is it stable enough? It seems to be. This is a compression model posteriorly. This is a professional former skier, 2-time Olympic medal winner. I'm not going to disclose her thing. I take responsibility for this 2-level L3 to 5 fusion. I did this, not proud of it, but this was, I think, 15, 20 years ago. Actually, 20 years ago. Charlie Ray Cages, a brilliant surgeon. Friend of mine, I was very privileged to know him. And the only American I ever met who can speak perfect Swiss German without having any German ancestry. So she now has the expected transfer disease. Remember my paradigm? 100% incidence of adjacent segment disease. However you do it, it's an unphysiologic procedure we have to do or do by choice. So expected adjacent segment disease. She had a compression fracture higher up. She had very good bone density. I talked about 1-2 level fusions or T10 to pelvis, which she'd always talked about. She said, absolutely not. After several discussions, I did a 2-level interlaminar process spacer device as an outpatient. I think she's actually now heading towards 2 years. She's very happy, and she's back in full active life. She looks, again, amazing for 81. The textbook answer would have been a T10 to pelvis fusion probably in most hands. So final, degenerative scoliosis, had a previous laminotomy at L4-5, very unhappy, saw multiple, a very nice, very well-connected person, saw multiple surgeons. Everybody told us some degree of fusions, ranging from T9 to pelvis to L2 to pelvis, et cetera, et cetera. In the interest of time, I'm not going to poll the faculty here, but we talked extensively about it. She said she had absolutely no back pain. She had leg pain and weakness. She couldn't walk. Yes, we did a single level, very careful revision decompression and interlaminar spacer. The x-rays are not perfect. She's extremely happy. Yes, one more time, I'm heavily conflicted with this company. Is this a cure-all? This is again, another farmer walked out, this is not what I wanted to show. I wanted to show some negative examples. This is not a cure. This patient with rheumatoid arthritis, we did a decompression. She did very well. From a neurologic perspective, she still has back pain. Am I going to operate on her? Probably not, but I'm certainly following her with great interest, and she's happy that she doesn't have leg pain. She still has the same amount of back pain, so I'm not going to claim that I have the cure-all at all. If you look at larger publications, and they're heavily influenced from the Far East, complications are between 3 and 15%, and the remedy for a surgery that has failed here is a fusion surgery, which is probably okay if we did a less invasive surgery. This is, again, a longer-term follow-up of an 80-year-old radiologist who's amazingly fit. He's of Dutch origin. He's an ice skater. And after many discussions, I did a single-level Coflex device on him. And at age 85, he came back because he had a, quote, clicking sensation in his back. And here you see that his spondy has worsened. His MRI, you see on the top, is very reassuring, but he has a clearly progressive degenerative spondy here. I told him, do you want to have a fusion done? And he said, absolutely not, and walked out. So we're still in touch. We're still friends. So the point is, let's not have a dogma. Let's be a little bit more thoughtful. Posterior midline exposure is potent and strong. And here's a real life and almost live thing. And anybody who doubts this can walk down with me one floor and see this patient live. She's post-op day 1, and she's going to go home either this afternoon or tomorrow morning. Works in the beauty industry, mid-40s, female. BMI 39, totally healthy, severe left lower extremity pain, weakness, back pain. She does have what is probably a grade 2 degenerative spondy. She has an eccentric collapse. She has a pretty large disc herniation of foramen. She has, and we don't have the CT here, a eccentric, very dysmorphic facet joint anomaly. After many discussions, even I, who likes to preserve motion, decided on doing a fusion. The statistics, and Dr. Hogshead can back me up on this, Under 3 hours surgery with an extensive splenic block, blood loss under 200 cc's, of course, no dural tear. Length of stay so far 24 hours, hopefully home this evening or tomorrow morning. Leg pin is gone, 10 centimeter incision. And this was done through an intradiscal osteotomy via an ATA approach. I think acronyms are what it takes to sell a surgery. And for those who don't know what an ATA approach is, like a PTP, ATA is a tergo approach, from the back, Latin. So this is, again, my pitch. Reconsider fusions. Are fusions truly minimally invasive? I think not. This is a biomechanical legacy that will at some point in time have reverberations in the rest of the spinal column. Let's reconsider clear indications for fusions. A lot of these grade 1 degenerative spinals I see, I would truly try to either do a decompression or stabilization over a fusion. And they're not a cure-all. I tell patients 15% by 5 years, you'll have to have a revision surgery. Flawless execution of what we're doing, of course. So do consider decompressions plus minus stabilization surgeries for the lumbar spine. And I'm an avowed fan of motion preservation. I love laminoplasties. I love cervical and lumbar disc replacements. I think that makes far more sense for degenerative disease than fusions, if avoidable. With that, I close. Keep it simple. Thank you.
Yeah, that was comprehensive. I'll go saying that has always been said, right? The young surgeon fuses, the middle-aged surgeon refuses, and the old surgeon refuses. Stop using it.
Well said. I'll quote you in addition to, I'll put that down in a quote, and in addition to the Wolverine spine. Thank you.